get going. As I see it, it is 3:15. At 4:15, Dr. Odorizio turns into a pumpkin and Dr. Wildering dies or worse. On the spot. I'm dead. Boom. All right, first question. I have a NET, specifically a gastronoma. I've developed type 2 diabetes. What kind of diagnostic test, Odo, do I need for my type 2 diabetes? And Vinic, could my treatment with sandostatin be screwing up which is the treatment for the gastronoma, be screwing up the type 2 diabetes?
So,
Odo, what do you need for type 2 diabetes diagnosis?
So the most accepted hemoglobin A1C now, I believe, is 6.5%. By definition, hemoglobin A1C of 6.5% is by definition accepted as diabetes mellitus. It's usually the non-insulin dependent, where you have adequate insulin or more, and your sugars are high. Having said that, and Arthur, I need his whole view on this too. But sandostatin octreotide, in general, suppresses. It's kind of paradoxical, because a lot of times with sandostatin you get a low blood sugar because it antagonizes a hormone called glucagon.
Or growth hormone.
Or growth hormone. Either one of those are both antagonists of insulin. And so you leave unopposed insulin, and you're prone to low sugars. However, my experience is that more often than not you get high blood sugars. But my experience is that the hemoglobin A1 rarely goes above 6.3 when it's octreotide induced, and you're not diabetes prone.
Okay.
You want Arthur to comment?
Arthur, can you talk about the relationship between sandostatin and developing diabetes? Is it common? Does it happen? And is it the kind of diabetes you have to worry about treating, or is it okie dokie?
Okay. Tom already alluded to the fact that sandostatin in different people can have different effects. In a lot of people, what it does is suppresses glucagon, and if it suppresses glucagon, it drops your blood glucose. But by the same token, when we have people who are making too much insulin and they have insulinomas, or they're hyperinsulinemic, we treat them with sandostatin, and under those circumstances you suppress the insulin. And if you suppress the insulin, you become hyperglycemic, and we've used that. And there's no way that we currently know of predicting who will go one way and who will go the other way. We actually treat people, we infuse it often with pump therapy, and see what the response is to the sandostatin. There's another way of answering that for you. There's a relatively rare tumor called a somatostatinoma, and when you see people like that who are making their own somatostatin, they will often make the precursor of somatostatin, and the precursor is somatostatin 28 versus somatostatin 14. Somatostatin 28 in those people tends to suppress insulin, so they become hyperglycemic, and that's one of the manifestations of an excess of somatostatin. Now, in your case, when you have too much gastrin, one of the reasons we're seeing so much type 2 diabetes in people with carcinoid tumors is the fact that they don't lose weight. They retain their weight. Only when you see the malignant aggressive varieties do we start seeing people lose weight. And it's with this maintenance of weight and increased abdominal girth and increased nutritional absurdities, I don't know. That we are seeing type 2 diabetes as well. But
all right.
One more thing that's important, and that is if you're making gastrin, you're going to miss a key point. And it's important for you. So if you're making gastrin, there are other hormones that get secreted with gastrin, and one of them is glucagon. Yep. So if you if you have a rash that looks like what they call the migratory necrolytic erythema, and or you measure glucagon and it's elevated, that to us has been one of the frequent causes of hyperglycemia.
And pancreastatin, there was an excellent paper written early on, I think 1992, which showed very clearly that pancreastatin is also associated with stimulation of glucagon in a hormone-hormone interaction, and that again can be associated. And some of the pancreastatin levels, if present, can probably be significant enough to cause this other pathway. And so that can contribute to excess glucagon in addition to what Arthur alluded to.
And if your gastronoma is part of the multiple endocrine neoplasia syndrome, and you're also producing catecholamines, so like interfere, that will elevate your glucose as well. So there are a whole variety of causes of why that actually happens.
And the other thing in gastronoma is you can co-secrete adrenocorticotropic hormone, ACTH, and that makes you cushingoid. Cushingoid gives you diabetes, a buffalo hump, stria, which are like stretch marks, rashes, hypertension, all kinds of stuff. Next question. For gastronoma, if you have all your lymph nodes left after debulking, what does the literature say, or why does the literature say the better prognosis is lymph nodes versus liver mets? I can't explain it. We're just into this discovery by 6 months. Stay tuned. 6 months from now, I may know. Does chemotherapy work better on more aggressive, i.e. greater mitosis tumors than less aggressive? Yeah, I believe so. That the higher your proliferative index, the more likely you are to respond to chemotherapy. Sandostatin, that's not true. Rarely do very high mitotic indices tumors respond to sandostatin.
Now, and the other point about the higher mitotic index, the PET scan, it's called fluorodeoxyglucose PET.
Plain old everyday PET scan.
The PET scan in this instance will usually be associated with a higher, what they call SUV. It's a quantitative number of representing the activity of a tumor. And the French now have published twice. The French an SUV above 7, some say 8, but an SUV above 7 tends to be more responsive to chemotherapy.
Okay.
Let me. This morning they talk about what Gene said about gene expression in the primary tumor on the node and metastases, that he cannot find certain gene as different area. From nutritional standpoint, it make a lot of sense, and there are data to support this. Basically, the microenvironment where the tumor is growing do regulate gene expression. So in essence, the microenvironment in the liver, the microenvironment on the bone, and the microenvironment in other area are different. That lead to a different expression of your tumor. And that's the reason behind, I didn't want to interrupt their nice discussion, but there's a nutritional concept behind it.
Okay, Dr. Go, this is the question I get asked 100 times a year. Does sugar cause tumors to grow? And if so, should I limit my sugar intake?
Tumor grow because they need nutrient. And most of the tumor do have receptor for glucose. GLUT5, there's a receptor for that. So basically, you need glucose for tumor to grow. That's basically anybody.
But can you limit your diet?
Let me finish.
Okay.
Let me finish. How much sugar you do is basically how you handle the metabolism. If your body has enough regulatory mechanism to control your blood sugar, then you'll be okay. Excessive sugar, or you have heard so much about fructose intake recently. That word came from our laboratory. Fructose seems to be bad to you, but it all depends upon how your body regulates. I don't agree with taking only sugar. I always believe in balanced diet, because between fiber, protein, carbohydrates mixture, it will alter the absorption of glucose, and the control mechanism is different.
Okay, I think what the question is, can I limit sugar intake in my diet and cause my tumor to stop growing?
No.
Thank you. Okay, thank you. Why does a big meal cause carcinoid patients a problem? Remember the 5 E's? One of the E's is eating. Odo, and what is a functional pathway? And I don't understand what does what to who.
Well, part of the pathway for the 5 E's, epinephrine,
No,
excitability.
eating. I'm asking
I know,
eating.
eating.
Big meal.
Okay, so eating, it's hard to implicate. I want to hear Arthur on catecholamines or adrenaline causing that, but we have seen eating cause bursts, and if they're in the duodenum, if they're mechanically, if you put a bulk of food in a tumor that rests in the duodenum, it's possible to mechanically release from the tumor itself. And I know that's for sure a mechanism if the tumor is proximal by the stomach. Arthur?
There are a couple of important issues here. When you're eating, and Bill Goh alluded to this, the foods that cause trouble for most people with carcinoid are tyramine-containing foods. Blue cheese causes trouble, red wine causes trouble, hot dogs cause trouble, dark chocolate causes trouble. All of these things are, I assume, to be part of the meal. But however, there are people that will flush and sweat profusely if you just dilate the stomach or you dilate the colon. And if you're straining at stool, you activate the autonomic nervous system, and what it does is makes you sweat and makes you flush as well. And I can go into a whole long explanation for that, but it does do that too. And if you simply put a balloon there and physically dilate the colon or physically dilate the stomach, you'll do exactly the same things. That's why it's preferable to eat small meals and to eat meals that don't contain all those tyramine-rich foods.
Now let me add, Gene. This is basically a function of gastric emptying, how the stomach empty your food after you're eating, and how good is your stomach in grinding. The stomach is basically your blender. That's what it is. The stomach is your blender. You put everything in there, it blends together. It becomes soft and become liquidy so it can be emptied. The major problem for us, if you have big meal, the blender is overworked, and then you have to add more fluid for the blending. So your stomach is distended. Now, if you're taking somatostatin analog, the emptying is being inhibited. It's slowed down. So you run to that kind of problem. So there is a physiological explanation why this is. We have done that work in human way back. If you want to read my paper, it's way back 1969.
Okay, moving right along. If patient experiences tumor lysis syndrome, for those of you who don't know what that is there are certain tumors when given a chemotherapy, the whole tumor just turns like mush and dies overnight. And the dead tissue is so much that it overwhelms your kidney, puts you into renal failure, and you die many times, not because of the tumor expanding, rather than the tumor died and your body can't handle the toxic side effects. There's a tumor in Africa called Burkitt's lymphoma. And these people have massive tumors of their head and neck. Give them one dose of chemotherapy, and the tumor's gone in 24 hours. But they lose their kidneys because of it can't handle all this stuff. So the question here is, if you get tumor lysis syndrome and your tumor just goes to mush, does that mean that this is probably a very good, effective treatment for eradicating your tumor? And the answer is yes. But again, remember the problem is eradicating a tumor doesn't mean you eradicate all your tumors. And what you saw today is if you got 22 tumors, you might get 21 of them, and the 22nd one gets you.
And the other thing, there's remedies for the tumor lysis syndrome. They have precedent with leukemia treatments, but uric acid inhibitors is a protective mechanism.
Allopurinol, Lasix,
and
bicarbonate, fluids, lots of different things. But if you don't know you're going to get tumor lysis syndrome when you get chemo, then all of a sudden the next day you wake up and your kidneys aren't working.
And you can explode a tumor as well if they're functional like a serotonin secretor. And we've seen this. We've seen it with hepatic arterial chemoembolization to the liver, which we don't do as much now. In fact, I haven't done any for 10 years. But the bottom line there is you're releasing hormone, which is very vasoactive. Right. And you can get shock kidney in that regard.
Okay, so when we are going into infarct, that is to kill off tumors, we always prep people, and we prep them with sandostatin in very large doses and steroids in very large doses, plus a lot of fluid, so we don't run into the syndrome. We prevent it, we anticipate it.
Question, is massage therapy okay for widespread metastatic disease? I guess, and this is going to sound like I'm being a smartass, but I'm not. It depends on what's being massaged. If you push on somebody's liver who has a liver metastasis, you're going to get that person in trouble. If you work on their knees and they don't have any tumor in their knees, I think you're just fine. So the answer is massage therapy is just fine as long as you're massaging the right spots. If you massage a tumor-bearing area and you push on it, you can release cancer cells. There's some wonderful work done by a guy named George Turnbull from the Cleveland Clinic on taking a breast cancer, and at the time of surgery, he put catheters in the veins, and then he took the tumor out, and just by moving the tumor, he dislodged tumor cells into the veins. So if you sit there and massage somebody's breast that has a breast cancer, those tumor cells are going to go away. Same way with your liver, same way with like a lymph node in stuff. So yes, if you want to massage somebody's feet, I think you're fine. Want to massage somebody's legs, you're fine, arms, hands. But I'm not so sure I would be getting my liver massaged with massage therapy. Okay.
Massage therapy is basically good for quality of life. Okay, if you take the precaution, of what Jean just told you, massage therapy is actually fairly good. I have a lot of cancer patients in general. The massage therapy is part of their quality of life, so I would not ignore it.
Paradoxically, there are patients who've come to us and told us that when they've had deep pelvic massage, that they get all their symptoms, and it's allowed us to identify where the tumor is.
Okay, there you go. Antidepressants. Do you limit the kind of antidepressants or recommend one kind? I can tell you from my perspective, I've not seen problems with people who've gone on Prozac, Elavil, blah, blah, blah. I know there is a serotonin syndrome with those things, but I don't think it happens very often. It's like anything else in the world. If it happens to one person out of 1,000 and you're that one person, you're in deep doo-doo. But the chances are you're going to be just fine. And I don't know if your family has depression. I have a younger daughter who has severe depression. And believe me, if she had carcinoid and depression, she'd be on antidepressants no matter what.
I'll explain the mechanism to you quickly. Is that serotonin itself doesn't cross the blood-brain barrier very readily. So it doesn't go from your tumor straight into your brain, because serotonin is what keeps you at peace. Its antidepressant action is what you need. The precursor, 5-hydroxytryptophan, is what crosses the blood-brain barrier, but the tumor is greedy. It's sucking up all that 5-hydroxytryptophan to make serotonin, so none of the 5-hydroxytryptophan is going into the brain. So the brain in people with carcinoid is deficient in serotonin. So it's a very good thing to treat them with serotonin reuptake inhibitors for the most part, and it relieves them of the depression.
And there has been recently, there's at least 3 cases reported of serotonin crisis from the serotonin reuptake inhibitors. And in general, I think then there are stronger ones and ones that last longer. In general, I think you should ask your physician to give you one with a lower concentration. And pardon me?
Combination SSRI.
Yeah, SSRI combination one, and try those too, because there are crises reported with the earlier drugs,
Okay.
Prozac and Zoloft.
I got to tell you, I don't limit anybody on any of those things, and I have yet to see a problem. Does that mean that somebody is not going to die when they get put on one of those? No, it doesn't. Just says so far I haven't seen it.
And you're on serotonin. I mean, you're on sandostatin for the most part, so that imparts some protection as an offset.
Okay, Odo, this is right up your alley. Can you expand on the gallium-68 scan?
Yeah.
That's not for a half hour, that's for 1 minute. If you have a baseline that is based on the Octria scan, i.e. if you have a positive Octria scan, Would you recommend switching to the gallium scans when it becomes available? Or are these going to be more difficult to interpret than Octria scans? And, wait, when will the gallium scan be available in the U.S.? And where will it be first?
Okay.
Vanderbilt is already offering them, but they only have permission to do 30, and then they're out of the game.
Then they're out of the game. So the machine was made in Berlin. It's shipped November 1st. We'll have it November 15th. The IND is prepared to go. We need to do 3 effective gallium-68 scans. We have the SOAP, which is standard of procedure, so that we will be able to submit to the IND. They wait. If they don't have rejection in 30 days, we'll be allowed to set it up. Number 1. Number 2, it's a PET scan, photon emission tomography, not a SPECT scan, which is Octria scan. It is very quantitative because it gives the average counts. It's a very high energy material, gallium-68. It bleeds or just becomes from germanium, becomes gallium-68. It's a very high energy, lasts only about 120 minutes, and they can get counts instantaneously. And you can look at the normal tissue next to the tumor, and it'll give you a ratio and give you an actual quantitative value called SUV, and it is very quantitative. And if you can see it by Octria scan, you'll definitely see it by gallium, but gallium is quantitative and will probably replace Octria scan.
Okay. Remember that there are a lot of things that give positive Octria scans and gallium scans. And those things are granulomatous disease, renal cell cancer, certain breast cancers, certain thyroid cancers, certain lymphomas. Not all that glows on a gallium scan is a neuroendocrine tumor. That's important to know. Bone mets. Arthur, what do you treat bone mets with? What's most effective? And from all this conference, how do we get this information to these folks' docs?
Okay. Getting into these folks' docs is another whole story, and I think that's really important. There's a lack of communication and physician education. Bone mets themselves, if there is a bone met and that bone met is not impinging on any neurological tissue like the spinal cord or a nerve root, there are a couple of ways we can go. We can go for direct radiation, but we treat every one of those people with bisphosphonate. The bisphosphonate of choice is permidronate, and we use permidronate in a 4-hour infusion and pre-med the people, and we can actually relieve people of pain and stop the tumor growing. The other approach to that it becomes if it is close to a nerve structure, close to the cord, and there's any risk of damaging these, that's exactly right. We go for cyber knife therapy to try and get that particular.
And one of the people here, I was wrong. I said cyber knife was $10,000. He informed me that he had 10 of them, and they were $100,000 a piece.
Yeah.
And so, and his insurance company paid $79,000. So, that's a chunk of change. We have 10 of them done.
Now, one caveat about the bisphosphonates that Arthur alluded to, permidronate is a very powerful bisphosphonate, and it stops the resorption of bone. And it behooves you to make sure you're taking on a very high dose of over-the-counter vitamin D of at least 2,000 to 3,000 units per day, because the problem there is you stop the bone from giving up calcium, and if you don't have enough calcium coming in from the intestinal tract, you can get profound hypoglycemia. We've had hypocalcemia. That's hypocalcemia, low calcium.
Tell your dentist that you're going to do this, because one of the problems is jaw reabsorption, and get a Panorex, which is a special X-ray of your head.
And one last thing that a lot of people have thought, because they can switch to the rapid infusion of like zolidronate, where you can give it over 15 minutes, it doesn't work. So we've gone back.
We
to
use Zometa exclusively.
Yeah.
Permidronate is
Permidrate.
60, 90.
Anyhow,
90 milliliters.
chromogranin A is affected by PPIs. Is pancreastatin also affected? Actually, this is a study that the group here is doing with a guy named Danny Rains, who is a young gastroenterologist in my office. We now have about 30 patients entered into that study, and these people have been on PPIs for at least 3 months. the gastrin goes up, the chromogranin goes up, but how you know that it is caused by the PPIs is your pancreastatin stays flat as a fritter. So if you think it's due to your PPIs, measure a pancreastatin. If it's normal, you can rest easy.
Very
That's really critical information.
consistently.
Dr. Go, what nutritional monitoring tests and activities should we use to monitor somebody like these folks who have tumors, and how often should they be done?
I don't have any recipe for you for monitoring for nutrition status. All I could say that your team who treated you, either surgeon or the endocrinologist right here on the table or the oncologist, be sure you have a nutritionist following with you. I think that lady or that person will be much helpful for you. The question about survey, I have a survey for healthy living and various cancer, lung, prostate, but I don't have one for neuroendocrine tumor. That's really one we need to work with. We don't have one.
Just from the clinical standpoint, there is a universal vitamin D deficiency, not only in the United States, worldwide. The measurement that we make regularly is 25 hydroxy vitamin D. If your level is below 30, you need vitamin D replacement. If your level is below 30 and you have diarrhea with it and it's incompletely controlled, you need to be on vitamin D replacement. And so we go to a standard administration of 50,000 units of ergocalciferol once a month.
All right, we're halfway done.
About vitamin D, this is really very, very, very key issue because we have done similar work. You'll probably be surprised if I tell you that the survey we have done in Southern California, Sunshine State, 1/3 of us are vitamin D deficiency.
Yeah.
Surprise you? We publish it, the American Journal of Clinical Nutrition.
All right, here we
So
go.
an instant vitamin D supplement had been encouraged in California, and part of that is basically we don't go out, or if we go out, we put too much sunscreen.
I mean, every woman now, Estee Lauder puts SPF 15 in everything. So, I mean, you know, unless you take off your clothes in some way or other in a bathing suit and go out and get some non-sunscreen exposed skin exposed to the sunlight, you're doomed.
The other thing that happens very commonly is a niacin deficiency.
Yeah.
So you recognize that, and let me tell you just a few of the clinical features which tell you that. If you look at the skin, you see a crazy paving of the skin, which is very suggestive, or what is called Castle's necklace.
Yeah.
It's a darkening of the skin around the neck. You see that, you need niacin replacement.
Yeah.
Okay, we're trying to get done with these, so we gotta
hoping that's
we gotta go.
you need niacin.
We gotta go. Can octreotide have a negative effect on growth or reproductive organs for a teenager? Odo, you want to talk to
Yeah,
that?
they did the study
Sure.
in ewes, sheep, and
Sheep.
there's absolute no interaction with octreotide at the pituitary for the reproductive hormones.
Okay.
The other part of that question though was
Growth.
growth. By the age of usually 19 or 20, your growth hormone level is starting to drop. And so you've
And your
reached
plates are
maturity.
fused.
And your plates are fused. So growth
Right.
hormone doesn't enter. I suppose, I know it probably doesn't, even in the geriatric population, late elderly, it probably isn't impacted, but it does inhibit growth hormone. There's no question. But it doesn't really have an
Effect on
full
growth.
effect.
All right,
And
time on the
it
card.
inhibits liver
Okay,
production.
how often
Yeah.
should
Yeah,
MRIs, octreoscans, scans, CT scans be performed in the first year following surgery? We do them at 3 months following surgery, then 6 months, and 6 months after that. We have a very competitive daughter, who I assume is the teenager. Will this negatively impact her recovery or treatment? I mean, that's part of the E thing. If she's exercising, if she's one of these people who's a balls to the wall kind of marathon runner, and she has carcinoid syndrome, I think it's going to make it worse. Yes. I think that you have kids who get into an emotional tizzy when it comes to academics, et cetera. And again, if she has carcinoid syndrome, that's going to make it worse. If she is non-functional, I don't think it's going to make her tumor grow faster.
No, but you can use short-acting sub-Q, and that empowers them very, very much. It's very straightforward. You give a shot of Sando, 30 minutes it peaks, it plateaus in an hour, and half of it's gone in 120 minutes when you give sub-Q. So people are in great control when they use the sub-Q prior to an event, a race. It can be done. You can control very beautifully the exercise-induced release.
Okay.
Do they perform better?
Okay. Yeah, they
don't.
do Macbeth better. After a primary site is surgically removed, can it come back? Yes.
Yes.
Speakers note the increase in nets. Has there been an increase in families, clusters of nets? What screening should be considered for noids? Now, not pancreatic tumors, but noids. What screening tests should we do?
Okay, so one of the interesting things, there are several families now who have more than one generation with noids or nets. This is not pancreatic nets. It's not multiple endocrine neoplasia. It's not type 1 or type 2. This is familial carcinoid syndrome. And we're finding more and more families like that who have this tumor. There are several centers now that are looking into the genetics thereof to see if, and there's a suggestion that there is a gene, not the a red proto oncogene, not the MEN1 gene, a new gene that has been uncovered that is circulating in certain families.
But
and
in
for
general,
screening, we do, if you have one family member and they want to know the other family members, we do the same things we told you about today. And that is to measure the 5-hydroxyindoleacetic acid, chromogranin, pancreastatin, and urocinin.
And I think I really do. The ones that we've seen, we have 5 families, and every one of them were related by their ileal tumors. Either their father had it of ileal, and the child had it. And so, because of that, we can exploit the midgut ones with serotonin. And we have now, in a family of 40, identified 3 at-risk patients based on their the children based on their serotonin level, and following them very closely. But that's the only one you really can do with serotonin well, because remember, that's where the tumor that has the highest serotonin levels.
My favorite question of the meeting.
Wait, one last thing. We also have families with people who have carcinoid groups like this where people meet each other, so we've got both sides.
Okay.
In several families now, so that we've got carcinoid from the husband's side and carcinoid from the wife's side with a familial transmission.
Yeah.
All right, everybody's going to have to. This is a legitimate question, so don't.
Did you ask it?
No, but I wish I had. Dr. Go, concerning alcoholic drinks, if you go for 3 days without a glass of wine, is it okay to drink 3 glasses on day 4?
That's a tough question.
Yeah. If you go for a month, can you drink the whole damn bottle?
Watch out for your liver
Yeah, really.
before I worry about your neuroendocrine tumor, because your liver will be burned out before you have problem with your neuroendocrine tumor.
3 days, I think, is fair.
Okay, any of the docs, if you've taken Zantac, 300 to 600 milligrams a day for 10 years, have you downregulated your cell receptors? I guess they're talking about H2 receptors.
Yeah, and Bill would know more, but Andy Ippoliti many years ago did studies with the Zantac, I think it was Zantac, the H2 blocker, and showed that although gastrin may blip, gastrin goes up a little bit, but then it comes down normally. So it does not impact the axis of gastrin, high chromogranin. The PPIs are selected for that because they inhibit the acid so much. Bill?
That's correct.
Thank you, Chinaman. How effective are CT scans and MRIs in detecting carcinoids? What is the small side carcinoid detected? CTs and MRIs are effective. I always tell people I can find routinely stuff that's 1 centimeter. The smallest size carcinoid I've ever detected was with the help of Dr. Odorizio and the thing called the Nia probe, which is a deal that's about this big, and it's a Geiger counter, and you put it in your hand, and you put the somatostatin analog, the Octreoscan, in the vein, you let it clear, and then you explore people and use the neoprobe intraoperatively, and we found using that a 2 millimeter tumor that we couldn't find any other way. If minimal lymph node presence in the thoracic cavity, is surgery worth it? You know, that's a good question. We are of the opinion that we're going after everything we can see to get you down to what's called R0, resected to the point where we've taken out 95 to 99% of your tumor. And we believe that that's true. Is the treatment with sandostatin LAR sufficient? As a lifetime therapy that you'll never need anything else if you have metastatic disease? I don't think so. It works for a while, and then the body figures out ways around it. Do you guys agree? I mean, do you think a person can live on Sando for the rest of his life and never ever have tumor progression?
Again, it's probably, as you've alluded to, it's probably got to do with bulk. But I think in the case of the lung one, you need to carefully weigh the risk of the surgery and obviously with the benefit. And I think once they've had the vast majority of surgery, something like PRRT with a very carefully done, in this case, gallium-68 scan may elude. But remember, we don't know the significance of a receptor after PRRT, because some schools of thought are there are more receptors after PRRT, and there's another school of thought that you diminish some, and that's good. So Europe has never given us an answer on that. So it's not unexpected after PRRT to have receptor-positive tumor remaining. We don't know, if anything, more receptors mean slower growth. So I think we got to be very careful with how many times can you go to the well in the lung, and that's the answer. That's the question. You have to be very careful with that, I think.
Certainly,
let me add to that one. I think the risk-benefit issue is really the key before you do anything on that. And then the other thing is that if the tumor is big enough, some superb pulmonologists be able to do endoscopic removal. And I've seen it done.
Thoracoscopic, that's exactly what I was going to say.
Endoscopic.
Yeah.
I've seen it done and have been successfully removed.
There's at least one person in this room that we took out all their abdominal tumor, and there was a hot spot on Octreoscan that we went after in the neck, and when we got there, it turned out not to be tumor, which was absolutely fabulous. So that's something else that can happen. Is it better to do PRRT sooner, like in Europe, or later, like we seem to do it with our patients in the U.S.?
So 5 years ago, all of Europe was taking stable disease and treating them. Now the recommendation from all centers in Europe is that they have to demonstrate progressive disease. In answer to that, that's a tricky one. If I treated it like we treat, Arthur and I treat thyroid cancer, you would extirpate, if we had it in the United States, we would extirpate the thyroid, take it out, and then treat with a swish and swallow with I-131. We don't have that luxury yet to answer that question in the United States. And that is that you take it out with carefully done one-time surgery and then go in
or multiple sequential surgeries.
And empirically go in and do the PRRT. We don't have that answer, and Europe hasn't given it to us.
But Europe will tell you that they get better response rates with less tumor volume. And the question is there a break point at which microscopic disease it's not worth the effort? Or is it at 1 centimeter or 2 centimeters? Nobody knows that answer.
No, but they do say, and I don't know how they quantitate, they do say 30% or less tumor burden. That's their clinical experience in Basel, Switzerland. Less than 30% tumor burden are better responders. That's what they say. But then we talk about how do you get reproducible volume percent.
Now that'll be easier with gallium 68.
68.
That'll be easier with that. When testing labs, chromogranin and pancreastatin, will they both rise together, or could CGA rise and pancreastatin drop at the same time? In general, the pancreastatin will go up, the chromogranin will go up or stay flat. It's pretty rare that your chromogranin's going up and your pancreastatin's coming down.
Yeah, and that, we think we don't have good data yet, but that pro-hormone convertase seems to be more active in the liver tumors. So when there is tumor in the liver, you tend to see the pancreastatin, and how much is a jump is going to be hard to determine. It may be as little as 200 picogram change. And be reflecting liver tumor activity. So
one thing I just want to point out to everybody in the room. Right now, Quest is going through a change in their assay for chromogranin. A, make sure that you know which chromogranin you're getting, and B, I can tell you from my own experience, there's some squirrely stuff going on with the Quest chromogranin assay. I would not make a bet the deed to the ranch right now until we sort those things out.
Yeah.
If your chromogranin's going fooky booky, just wait. It may be straightened out in 3 to 6 months.
Just hold a moment. Paris, would you like to address that issue? We'd like to hear from InterScience as well.
On the chromogranin A?
yeah.
I think the Quest test right now is requiring a serum only. And I think InterScience is a serum plasma, and we've kept the upper limit is 40.
40.
Yeah, and that's been consistent, I think, for 3 to 4 years right now.
Because at one point, Gene and our group tested we looked at their chromogranin A assay with Quest.
Correct.
And it was pretty darn good.
They were absolutely comparable. A Quest versus ISI, that's called split tube testing. In other words, you take the blood out of the tube, you put it into 2 tubes, you send it to this lab and that lab at the same day, and then compare them head to head. If they're both good, then you say thumbs up, like the Quest and the ISI chromogranin. I never said send your chromogranin's to ISI. Said send your blood to Quest, and they would take off the chromogranin and do it themselves, and which was fine. And they'd send the pancreastatin and neurokinin to ISI.
Yeah, let me answer that question also. I came from United Kingdom for this issue has been heavily discussed at the UK Ireland NETS meeting 2 weeks ago. The major problem for the assay, at least in Europe, they have standardized because the antibody they use see the same spot of that big molecule. Pancreastatin is part of a big chromogranin A structure. And the major problem we have here in the United States, I could assume that each of the antibody, as been discussed by Mr. Mamikunian, that probably the different laboratory antibody they use are seeing the different part of the molecule. I'm not saying that they don't know what they're doing. I'm also saying is that they're recognizing the different part of the molecule and give you a different answer. So in the United States, we need to standardize what antibody we want to use to measure chromogranin A. That's the message I got from Europe.
And so far, pancreastatin, we've cleaned that up a little bit with looking at the University Reference Lab in Columbus, Ohio, and the one at InterScience Institute. We cannot speak to anybody else doing pancreastatin levels, but those are 2 reliably reproducible, calculable assays.
Okay.
In my position as associate editor of one of the journals that does all these reviews, I received the paper from Europe, and they point out an interesting phenomenon, that if you use more than one of the chromogranin assays, you get a better sensitivity and specificity. So that's not the end of the story. Okay,
Harris, how can we get insurance companies to pay for InterScience's pancreastatin tests?
Wow. I gotta handle this one.
Hey, it says Paris on it. You know, I'm not in France.
Well, I'm not even close to answering that one.
I think that things I tell people to do. A, write a letter. B, write, and when they reject it, have your doctor write a supporting letter. C, send the copy of the paper that Dr. Odorisio wrote on pancreastatin to them, showing them that it is more sensitive than chromogranin, 5-HIA, and other markers. And remember, in every state, you have an ally, and very few people using, and that is the insurance commissioner. That is the guy that is your representative, that works for you and gives the licenses to the insurance companies to practice insurance or sell insurance in that state. And if you go to him and show him objective evidence that pancreastatin is a better deal than chromogranin, he will work with you, and in one letter from him, people start, their ears perk right on up.
I just want to add one little thing to that too. Is before the development of NANETS, that's the American Society that now has developed guidelines published in Dr. Go's journal. There is, in the diagnosis section of that, a recommendation that you use pancreastatin measurements. So now you have not only Dr. Odorisio's paper, you have the national organization recommends that you do this measurement. And so you take this paper plus the NANET guidelines when you go to say, here's our documentation.
That's really very, very important. I think the NANETS did a great service to do the consensus guideline, which, as I said, was started by Dr. Woltering. And since we got that article published, several insurance companies have asked me about of how we arrive at that document. The reason why they're, at least we're talking about in the West Coast, Blue Cross Blue Shield was asking that, Kaiser has been asking that. The reason behind is that there is now a document telling them that it worked. It telling them that there is a national, international group says this is what you should do. So it's very important for you. That's why I give you the website. It's really doing for you that I put that whole journal access for you to get it, so you can access and print it for it if you wanted to, then bring it to your doctor. And some of the insurance already allow it because of that. Prior to the consensus guideline, very difficult for you to find any fight any of your insurance company. But now you have a document in your hand that you can ask for it. It needs an authorization. And if they authorize you to have it, then it will be done.
Dr. V, can peripheral neuropathy come from progression of NETs from the treatment like sandostatin, everolimus, or surgery?
Okay. It's a long answer, and I know that I'm going to
God.
get my fingers wrapped.
We all got 15 minutes,
So-
and then I'm going to turn into a pumpkin.
So quickly, let me tell you, is that sandostatin itself does not produce a neuropathy. It may if it's causing malabsorption, but that's exceptional. The deficiency syndromes that were alluded to here, if you are thiamine or B1 deficient, you will develop the neuropathy as well. Some of our patients who have NETs happen to have them as gastric NETs, and they have atrophic gastritis, and they become B12 deficient. So we see a B12 neuropathy in those people. And then the last group that we see is what I call paraneoplastic. They're making antibodies to nerve structures. We do very simple measurements. We measure the antibodies in their circulation to nerve structures because those people are very easy to treat. We treat them with immunosuppressive therapy, and we get rid of the neuropathy very quickly. The last that is occurring now is what we see with the tyrosine kinase inhibitors. The hand-foot syndrome with the tingling fingers, the feet, that's not so easy to treat. We're using very large dose antioxidants, predominantly alpha-lipoic acid to treat those people. It's over the counter, 600 milligrams twice a day.
Nutrinerve.
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 The B12 deficiency is very critical among people of our age, or my age, whether I have NETs or not. So it's very... Yeah. Yes, right. So it's very, 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 very important to check for the B12. You heard about the B12 injection before. They're not. It's very, very, very common among people of our age.
And even a trial of B12 shots, because the B12 level is a little bit variable, isn't it, in terms of measuring it?
And one more little thing about that is because up to a third of our patients have type 2 diabetes who have NETs over here, they've been treated with the drug metformin.
Yeah.
Metformin is causing a lot of B12 deficiency in this country with time. So
That's
you need
very
to
good
remember
point.
that as well.
That's actually, it's a very good point. That's part of the examination for the medical student in our school.
Okay, quick and dirty. What causes crystals in the urine? Could it be due to sandostatin or everolimus? Odo.
I'm not aware of stone formers from sandostatin, but
No stones, just crystals.
I'm not aware of any crystals with sandostatin.
All right, moving right along.
I can't talk about everolimus.
Okay, is there a possible correlation between antiphospholipid syndrome and carcinoid?
Antiphospholipid?
It's
The phospholipid antibodies syndrome that you talk about is associated with an increased predisposition to thrombosis and bleeding. And I don't know of any association with that. However, antiphospholipid antibodies are frequently present in people who have nerve damage. We see that in nerve damage. So it could be with the paraneoplastic syndrome, but I stopped measuring those because the return was negligible.
There was a large, before octreotide came into being, they used to use native somatostatin. Serono made a natural product of somatostatin, and they used the model they used was the monkey, and they had at infusion levels of over 100,000 micrograms. There was a small association of thrombosis. Yeah, that okay. Yes, of thrombosis,
Okay.
but it's never been shown, I don't believe, in massive doses with octreotide.
Can a pregnant woman consume Chinese sweet leaf tea or black raspberry powder? I wouldn't, because of its anti-angiogenic effect on the uterus and the implantation. Patient has a 4-millimeter tumor in a lung. How would you work this up? Repeat scans to look for it growing.
And there are pulmonary criteria, and that have to be observed because there's standardized criteria. The one thing we talked about was the CT and the sensitivity.
10 minutes.
It is very, very sensitive in the lung. It might be because of all the air around in the lung, but CT can see below 5 millimeters in most cases.
Right, 2-3 millimeters.
2-3, yeah.
Yeah.
And so you are safe to follow that for growth.
Yeah,
It's
absolutely.
and
I have midgut nets with metastasis to lymph nodes. 12 months later, CT.
I incidentally also add FEV1. That's to get a pulmonary function test measuring expiration, because that's the first thing that goes.
With
is
something that's 4
prolongation.
millimeters?
Now, when it starts producing, they can produce very small.
Yeah, Gene, before we proceed, I just want to be sure that you guys agree, knows about it. We're not practicing medicine in Washington, D.C.
Right.
because we're not licensed to practice,
Yeah.
okay? We are here providing
Even more in Virginia.
providing not even in Virginia. I'm
Just
allowed to practice in
Arthur has
Minnesota.
a license to practice medicine. So everything we said came through Arthur. He was our mouthpiece. I have midgut nets with metastasis to lymph nodes. 12 months later, CT shows a 3-millimeter liver lesion and 4-millimeter node in the liver. How long do we just watch these areas? Forever. Biopsying something that's 3 millimeters is akin to throwing a knife at a speeding bullet and trying to hit it. 3 millimeters you just can't do. Watch it over time. Watch it grow. Do an MRI with gadolinium of the liver. Hydrate yourself so that you protect yourself against Steven Johnson and all those evil things. And that's something you're just going to have to watch. You can't biopsy something 3 millimeters.
No, and the biochemical measurements will be very assuring. Honest to goodness, the pancreastatin is that good in terms of seeing. Remember, the levels will rise before the CT shows anything.
Yeah, I mean,
You
you're
want to
so
progress-
early in the game that you're over worrying in that one, I think. If it is, it's going to grow. If it ain't going to grow, and you're going to be a happy camper.
Time up.
Oh.
4:15.
Nope, you got 6 more minutes. Do you accept major insurance? Everybody does. Patients who had surgery with your group in prior years have their tumor samples tested for common genes. No, but in many patients who were operated on, we have cryopreserved your tumor. It is still alive and well. And when we get the gene stuff done, we'll be able to wake it up like out of suspended animation and do that. But again, this is going to be very expensive stuff, $2,000-3,000 to do that. I have a well-differentiated PNET and had the primary liver mets resected. Now I have new liver and bone mets. Would you do a biopsy of my current liver mets to personalize treatments? Is there another way to personalize treatments? You got to have living tumor. And yes, we do that all the time. Woldering Vinnick, test done at Johns Hopkins. My pancreas biopsy said poorly differentiated pancreatic tumor. My path report after Whipple said highly differentiated. Which should I believe?
Both.
One said poorly differentiated, the other said well differentiated.
Okay.
No, you said well or highly?
No.
Highly differentiated or poorly differentiated.
One of the things when you read that is you need to know the other things that Dr. Odorozia mentioned to you. We want to see if there's a synaptophysin and a chromogranin stain for the prediction of whether or not this is poorly differentiated or
remember,
well differentiated.
For needle biopsies, the key thing to look for is the word crush artifact.
Right.
That when you take and suck Gene Woldering through a keyhole, I don't look in my fat little chubby self, I look like a pencil, okay? Same way when you suck cancer cells through a fine needle, you can elongate them, you can scrunch them up and make them look totally different. When they take out your whole pancreas as a Whipple and lay a piece of meat on the table and cut through it with a sharp knife, you don't get those distortions. If I was going to trust a needle aspirate versus a piece of meat on glass, trust the piece of meat on glass every time.
And then you also need to know, when they've taken out the whole pancreas, you want to know if they found any lymph nodes, if they removed those, whether you're going to believe that this was a well-differentiated versus a D-differentiated.
Yeah. Let me add to that. There's a case report about Dr. Tomo Derisio talk about the mixed tumor, endocrine exocrine tumor. And when you got the whole tumor in your hand, you want to be sure that you're not mixing a neuroendocrine tumor in the presence of pancreatic adenocarcinoma.
Yes.
Those are very, very critical. The exocrine endocrine mixed tumor is becoming a very, very critical issue to be addressed. So my answer, in addition to what Dr. Woltering tell you, you have to talk to the pathologist whether he have got a multiple slice of that tumor, not only slice one and look at it. And if there's any discrepancy, go a multiple sectioning of that tumor just to be sure it's not a mixed tumor.
And remember, there is a national resource. It's called the Armed Forces Institute of Pathology. If you're in East Fubu, Virginia, little teeny tiny town that's a one-horse town, and you don't trust your pathologist, it is free as a service. He can send your tumor to the Armed Forces Institute of Pathology and have them review it. It doesn't cost anything. It's why you pay federal tax dollars. And it's something to remember. 3 really quick questions and we're out the door. Besides Ki-67, what would you do on fixed tissue to look backwards? I do the chromogranin stain. I do the synaptophysin stain.
And for peanuts, the hormones.
I would look at the number of blood vessels per high-powered field. And for, as Dr. Vinnick said, for pancreatic tumors, I would stain them for hormones, with the caveat that because your tumor stains positive for insulin doesn't mean you have an insulin-producing tumor. It just tells you that the tumor has insulin in it. Doesn't mean it releases it. Doesn't mean you have insulin hyperproduction syndrome. Can you speak to patients who have metastatic midgut carcinoid?
Quickly. If the tumor has got insulin on it, it's not an adenocarcinoma. It never is.
No. These are neuroendocrine tumors.
No, but by definition, it becomes a neuroendocrine tumor.
Well, this is somebody that had, this is old, 10 years ago. Okay. If they, no,
Question?
Yeah, sure. Chromogranin, synaptophysin, Ki-67, factor 8, CD31, they're in all my notes. It's what I did. I stained them for. And then if they're pancreatic nets, with the proviso that I said, you stain a pancreatic tumor for insulin, glucagon, VIP, somatostatin, pancreatic polypeptide.
That's enough.
That's enough. Okay. Patients with metastatic midgut carcinoid, low Ki-67, all tumors removed, and no syndrome. Is it okay to watch and wait? I don't think you got a lot of choices. What would you do if you had no tumor and you had no syndrome? How do you fix perfect?
No. I think the issue is how long do you do that for?
Well, what we do is biomarkers every 3.
That's exactly
Scans
right.
every 6.
That's correct.
For a number of years. Now the
5
question,
years.
would I do that
And then we say
for
you're
20
okay.
years? No.
No.
I'd probably do it for 4 or 5.
We go for 5.
Right.
We do 5.
Okay.
Any thoughts on this tumor being congenital? You talked about that. When I did a sample size of 13, is that a factor in drawing conclusion? Yes. And we're continuing to add. Those cases turn out not to be that common, where on the same day we take out a primary, lymph nodes, and liver. And so whenever we get the trifecta, those go into that study. Discussion of the role of valproic acid in treating carcinoids, unknown. The guy to watch is Herbert Chen at the University of Wisconsin. He has a ongoing prospective trial of valproic acid, and I think that when we see his stuff, we'll be able to add to it with the black raspberry.
And you saw Dr. Go was acknowledging the endocrine clinics of North America. Chen has written a whole chapter on that pathway in that clinic's issue.
It's called the
It's
Notch
available.
1 pathway.
Okay.
Dr. Eric Lew at Vanderbilt, Gallium-68, Dotatox scan now, correct?
Well, it was there, but it's only. I think I heard it was only 30 cases.
under an RRC.
RRC, and they're going to have to come up with a protocol after that, because they can only bring 30 in to do. That's by definition.
Right. And then he has to have an IND, like you and Sue would have.
Yep.
Thank you all, ladies and gentlemen. We went over 2 minutes, but we appreciate you.